Good afternoon, everyone. Thank you for joining today's webinar, the Fiscal Year 2022 Hospice Final Rule, What Hospices Need to Know. My name is Rachel Boglai, and I will be your moderator for today. Our agenda today includes the following. 1, background of the Hospice Quality Reporting Program. 2, Fiscal Year 2022 Hospice Final Rule. 3, public reporting. 4, other updates. And 5, resources, wrap-up, and questions. Now I would like to introduce today's speakers. Ms. Cindy Massuda joined CMS in 1999. Since 2015, Ms. Massuda has been the Hospice Quality Reporting Program Coordinator within the Centers for Clinical Standards and Quality. Prior, she worked on Medicare demonstrations with a focus on hospice in CMS's Office of Research, Development, and Information, and Centers for Medicare and Medicaid Innovation. Mr. Charles Padgett is a registered nurse who has been in practice for more than 15 years. For the past 10 years, Charles has been a nurse consultant at CMS in the Division of Chronic and Post-Acute Care and has worked extensively within the post-acute care settings, including hospice, on policy and quality reporting. Most recently, Charles has led the post-acute care public reporting efforts, including the development and maintenance of the Compare sites, including Hospice Compare. Previous to his work at CMS, Charles worked with the clinical research and emergency medical field. Ms. Brenda Karkos is an associate nurse researcher at Apt Associates. She is an RN with many years of clinical and administrative experience in community health, hospice, and oncology. She is certified in hospice and palliative care and currently serves on the board of directors for the Hospice and Palliative Care Federation of Massachusetts. Before joining Apt, Brenda was most recently the director of a hospice program in Massachusetts. Her work at Apt is focused on hospice, oncology, and home health projects. Slides 5 and 6 in the deck contain a reference list of acronyms that will be used throughout today's presentation. At the conclusion of this webinar, we would like training participants to be able to 1, discuss the background of the HQRP. 2, list 3 important changes to the HQRP based on the fiscal year 2022 Hospice Final Rule. 3, describe the hospice information that will be publicly displayed on Care Compare in fiscal year 2022, and summarize important updates to the HQRP. Now I will review a few housekeeping items. This webinar is being recorded. It will be posted to the CMS Hospice Quality Reporting Program website, and we will provide you with details on accessing the recording via email when it is available. The phone lines will be on mute for the duration of the presentation. If you need technical assistance during the webinar, please let us know by using the Q&A panel to the right of the presentation. Additionally, you can use the Q&A panel to submit your relevant content-related questions. We will end the webinar today with a live Q&A session and will address as many of the questions submitted as time allows. To the right of your screen is an important information panel. This panel contains information on using your phone to dial into the webinar, a link to the slides being presented, as well as how to access live closed captioning features in your browser. If you need assistance accessing this feature, please let us know using the Q&A panel. Throughout today's event, we will be using polling questions. The polling questions allow the speakers to gauge your understanding of the material being presented. Each polling question will appear automatically on your screen. Please review the answer choices offered and submit your response by clicking on the circle to the left of your response. You can change your response at any time before the poll is closed. Your answers are confidential and will only be reported in aggregate percentages. Now let's try out the polling function with our first question. You should now see the polling question appear next to the presentation on the webinar screen. The question is, according to the meteorological definition, August 31st is the end of which season? A, spring, B, summer, C, fall, or D, winter? Let's wait a couple of seconds until the results stabilize. And let's go ahead and publish those responses. The correct response is B, summer. As a reminder, we will conclude the event today with a final wrap-up and a Q&A session. If you have any questions throughout the presentation today, please submit them via the Q&A panel on the right side of your screen. It is now my pleasure to turn the session over to our presenters, Cindy Massuda, Charles Padgett, and Brenda Karkos.
Thank you, Rachel, and thank you all for attending today. I am Cindy Massuda, and I am pleased to welcome you to today's webinar to discuss the changes to the Hospice Quality Reporting Program based on the fiscal year 2022 Hospice Final Rule. We're going to start with background of the Hospice Quality Reporting Program. The Hospice Quality Reporting Program was established under Section 1814 I-5 of the Social Security Act. It established quality reporting requirements for hospice programs. This included a requirement for the public reporting of quality measures that relate to care provided by all hospice programs across the country. These next two slides review the timeline events related to the HQRP for hospices. These key dates highlight when changes or additions were made to the Hospice Quality Reporting Program. We're going to walk through these so you can see how the Hospice Quality Reporting Program has evolved. Starting in July 2014, data collection using the hospice item set began. The data that was collected at that time included data needed for the 7 HIS-based quality measures. In April 2017, data collection for the visits measure, the hospice visits when death is imminent, or HVLDL, began when Section O was added to the HIS. At that same time, measure calculation for the hospice and palliative care composite process measure, which is 3235, the NQF 3235, began. Then in August of 2017, the Centers for Medicare and Medicaid Services launched the Hospice Compare website, and with that, the original 7 HIS quality measures were published and displayed for all hospices. In February 2018, the Consumer Assessment of Healthcare Providers and Systems, otherwise known as CAPS measures, were added to the Hospice Compare. And then on the next slide, as you can see, as of December 2020, Hospice Compare was retired, and Care Compare replaced the original Hospice Compare website. We have the link. Care Compare is a streamlined redesign of the original 8 CMS Healthcare Compare tools. Hospice Compare is one of those tools. Like the original Hospice Compare tool, consumers can now select and compare multiple hospice agencies based on their quality measure information. The link to Care Compare is listed on this slide. Then, in February of 2021, the Office of Management and Budget, or OMB, approved the new hospice item set, which allowed us to officially remove Section O, service utilization, from the HIS discharge assessment. Section O is used to calculate the hospice visits when death is imminent measure. This has now been replaced with the claim-based version, hospice visits in the last days of life, otherwise known as HVLDL, eliminating the need for hospices to manually submit the visit data. Now I want to take a minute to briefly review the annual rulemaking process. So we'll now look at the annual rulemaking process. This overview should help to appreciate how this process works and changes are made to the Hospice Quality Reporting Program. The fiscal year hospice proposed rule publishes in April. At that time, CMS provides a 60-day comment period that allows hospice providers and other stakeholders to consider the proposals and submit their comments. CMS reviews those comments and then responds to them via the final rule. The fiscal year hospice final rule is expected to publish every year in August and is effective 60 days later on October 1st. In April 2021, CMS issued the fiscal year 2022 Hospice Proposed Rule on the CMS website. The Hospice Quality Reporting Program Announcements and Spotlight page posted the announcement, including links to the proposed rule to give providers ample time to review and comment. This year's rule was referred to as CMS 1754P, P for Proposed Rule, and it provided updates to the proposals for the fiscal year 2022 HQRP. This is just a screenshot here of the proposed rule. The rule was then finalized on July 29, 2021, and this was highlighted on the HQRP Announcements and Spotlight page with a link to the final rule. A PDF version of the fiscal year 2022 Hospice Final Rule was published on August 4, 2021. Starting with fiscal year 2022, there are 3 sources of data used to fulfill that Hospice Quality Reporting requirements. These include the HIS data collection and submission, the CAHPS Hospice Survey submission, and then administrative data, Medicare claims in this case. It's a requirement that all Medicare-certified hospice providers must comply with these reporting requirements for all patients, regardless of payer. It is important for hospices to meet these requirements in order to avoid a payment reduction for the following fiscal year. Up until now, that reduction has been a 2% penalty for those that fail to comply. However, starting in fiscal year 2024, the reduction becomes a 4% penalty. We'll cover these changes in more detail later in the presentation. Now I'm going to turn the slides over to Brenda Karkos, who will walk us through a polling question and then continue with the presentation.
Yes, thank you, Cindy. So here's a polling question for you. So how many days do hospice providers have to comment once the proposed rule is published each fiscal year? Is it 15 days, 30 days, 90 days, or 60 days? We'll give you a few minutes. Answers are still coming in. Okay, I think it's slowing down. We can probably publish the answer. Okay, so the answer is 60 days. Most of you answered 60 days. So hospice providers have that much time to comment once the proposed rule is published. Okay, so let's go into some of these the important information from this year's Hospice Final Rule. So here's just an overview of the changes. I'm going to walk through this list, but be sure that we're going to discuss all of these in more detail throughout the presentation. So in terms of this year's rule, as an overview, the HQRP now consists of 4 quality measures. The 7 individual HIS process measures have been removed. Claims-based measures have been added, and those are the hospice visits in the last days of life, or HVLDL, and the Hospice Care Index, otherwise known as HCI. For public reporting, CMS clarified the display of quality measures and other hospice data that providers and consumers will see on Care Compare. And CMS also introduced the idea of CAHPS Hospice Survey Star Ratings. There was a revision to regulation number 418.306B2, which adds language in regard to the 4% payment penalty for failure to meet the HQRP requirements. And this will start with FY 2024 annual payment update. There is also a revision to Regulation 418312B, which requires the collection of administrative data, including claims data. Next slide. So let's start with the removal of the 7 HIS process measures as individual measures from the HQRP. That means that there will be no scoring on the individual measures on Care Compare. However, these 7 process measures are still used to calculate the more broadly applicable measure, NQF 3235, Hospice and Palliative Care Composite Process Measure, the comprehensive assessment at admission. So it's important that you know, in order to meet the requirements for the HQRP, you must still submit those 7 measures. This composite measure, comprehensive assessment at admission, will report the percentage of patient stays during which the patient received all care processes captured by the 7 component quality measures. And as you can see on the graphic, despite this change, the HIS admission and the HIS discharge is still required. So this slide shows the measure NQF 3235 in bold letters. And under that measure, noted in bold, you can see this list of the 7 components that make up this composite measure. And as mentioned on the last slide, the measure reports the percentage of patients that received all of these care processes captured by the 7 component measures. And that's asking the patient about treatment preferences, were their beliefs and values addressed, if that was preferred or desired by the patient? Was a pain screening conducted? Was a pain assessment completed if it was warranted? Was there screening for dyspnea? And then documenting the type of dyspnea treatment, if any was needed or initiated. And lastly, for patients who are being treated with an opioid, some documentation that they were started on a bowel regimen. And then this slide is just showing you that although you're still required to document all 7 care processes, the measure that is going to be publicly reported for fiscal year 2022 is just the 1 care composite measure, NQF 3235. So let's discuss a little bit more on the impact of the removal of these 7 measures. We spoke about care compare, but this also impacts the annual payment update, or the APU. CMS will no longer apply the 7 individual measures to determine compliance with HQRP requirements. This means that they no longer affect the APU individually, and beginning with calendar year 2022, that data will impact fiscal year 2024. The HIS composite measure remains part of the HQRP requirements and is not only now only 1 HIS-based measure that's going to be reported on Care Compare. But again, it's one of several measures that will be used to determine your compliance with your APU. In terms of public reporting, although the details on the 7 individual HIS measures will be removed from display on Care Compare no sooner than May 2022, providers will still have an opportunity to review the results of these 7 measures on their confidential quality measure reports, along with information about the HIS composite measure. Now let's review what's needed to be compliant with the HQRP, not only for calendar year 2022 data, but beyond that. All hospices need to meet the 90% threshold requirement for HIS submission, and this means that 90% of the HIS records need to be submitted and accepted into the system by the 30-day deadline. And hospices must participate in the CAHPS hospice survey to avoid a reduction in their APU. The APU reduction will increase beginning FY 2024, again, which is the data that's going to be collected this next calendar year. So starting with 2024 fiscal year and all subsequent years, the increase will be from 2 to 4 percentage points as a penalty for hospices that don't comply with the HQRP. And you can see from the table shown that all of the data collected now in 2021 will impact fiscal year 2023, and then again 2022 will impact 24, and from then on it will be a 4% reduction in a penalty if hospices don't comply in the next year. What? So the HQRP now includes administrative data or claims-based measures at this point. The HQRP has added these claims-based measures, which is similar to every other CMS quality reporting program. The 2 claims-based measures that have now been added, as we mentioned, are the hospice visits in last days of life, or HVLDL, and HCI, the Hospice Care Index. So this slide just explains some of the reasons that claims-based measures were added. First of all, the data used for claims-based measures are readily accessible. Using claims data minimizes provider burden, since there's no need for providers to collect and submit the data, such as the information for hospice visits measure, HVWDII. And when quality data is submitted through claims, it means that hospices are 100% compliant with submission. Claims-based measures complement the quality measures that are already in the HQRP and those that are being considered for HOPE, the assessment tool currently being tested. So let's just talk about the hospice visits and last days of life. So this measure has now replaced HVWDII, which is the claims-based, visit measure that used to be collected with Section O. CMS will now solely rely on existing administrative data or Medicare claims for the calculation of this measure. And as mentioned earlier, the use of the claims minimizes provider burden by removing the need for a clinician assessment and the collection of that data to submit to CMS. Hospices no longer need to collect the HIS data that was contained in Section O on the discharge assessment. So here's just again how the measure is calculated. The HVLDL measure is the hospice provider's proportion of patients who have received in-person visits from a registered nurse or medical social worker on at least 2 of the final 3 days of a patient's life. Let's just look a little more closely at this measure by looking at the numerator and the denominator. I'm going to start with the denominator on the bottom. So the denominator for this measure is all Medicare hospice decedents discharged due to death within the reporting period. And the numerator is the number of patient stays in the denominator in which the patient or the caregiver received in-person visits from registered nurses or medical social workers on at least 2 of the final 3 days of life, as captured in the hospice claims. So a little bit more about calculating this measure. The calculation of the last 3 days is unchanged from the previous measure derived from Section O. These 3 days are the day of death, the day prior to death, and 2 days prior to death. And the day of death is the same as the information that you collect in item A0270, which is actually the discharge date, or in this case it would be the discharge due to death. And then 1 day prior to that, it would be that date minus 1, and 2 days prior to that would be that same date minus 2. Any visits occurring after the patient's death does not count toward this measure and the score. So in other words, the pronouncement or postmortem visits would not count for HVLDL. So in terms of exclusions, these are the same exclusions as they were with the other visits measure. These are the patient does not die under hospice. So if they were discharged for another reason, they wouldn't be included. A patient who receives any continuous home care, respite care, or general inpatient care in the last 3 days would not be included in this measure. And a patient who was enrolled in hospice for less than 3 days. And since HVLDL looks at visits in the last 3 days, the patient must receive hospice services for at least 3 days to be included in the measure. And you can find more details on the current measure webpage. The link is on this slide as well as in the resource slides that are going to be at the end of the presentation. So next we're going to talk about the other claims-based measure, and that is HCI. So HCI is comprised of 10 claims-based indicators to comprehensively represent different aspects of hospice service throughout the hospice stay, not just at the admission and discharge like the HIS measure. HCI indicators reflect several aspects of care and hospice service that include things like the level of care provided, the frequency and timing of clinical visits, transitions to and from hospice care, and Medicare spending. And you can see in this graphic, and I'll show you that a little more closely in the next few slides, all these measures, indicators rather, go to create what is the hospice care index. So the current HIS measure only collects data at 2 time points, that is the hospice admission and the discharge. And HCI is really created to help fill that gap in between. It'll add value by filling information gaps in several aspects of hospice care throughout the hospice stay using available claims data. and HCI's data source, Medicare claims, is already collected and submitted to CMS. And on this slide, just another picture of that graphic and larger. You can see all the 10 indicators that make up the Hospice Care Index. And we'll go over this a little more detail in the next few slides. So the scores for these 10 indicators for HCI are combined to create one single score so that hospices can easily be compared. The addition of HCI to the HQRP will offer a more comprehensive and holistic view of hospices and should help patients, families, and caregivers by providing them with more information to make the best possible decisions about hospice services when it really matters. So we'll talk a little bit more about how this is calculated. So based on CMS's statistical analysis of national hospice performance, the criteria were set to ensure a meaningful distinction between hospices. A hospice is awarded a point for meeting the criterion for each of the 10 claims-based indicators. And then the hospice given indicator score determines whether hospice earns a point for that indicator or not. Each point earned contributes toward that full index score. And HCI scores can range from a perfect 10 or a 0. Let's go to the next slide. So here's just a simple example of a particular hospice, not a real hospice, and showing you the 10 measures, the 10 indicators, and how this would kind of contribute to the score. So in the first column header, you can see the indicators, and then in parentheses, the hospice score units, kind of so how this indicator is going to be scored in the units that we're using. In column 2, you can see the hospice earns a point for that particular indicator and how they earn the point. So whether it's they have to score above 0 or below 90%, or you can see in the last 3 they have to score above a 10% ranking. The third column is whether they earn the point or not, and then the last column just tallies up the points. So let's just walk through this example. So for provided CHC and GIP, the score needed to be above 0%. And in this case, the hospice did provide some GIP or CHC during the period that was being reviewed, so they received a point, so +1 in that last column. For gaps in skilled nursing visits, so this would be the percent of elections, the hospice needs to be below the 90th percentile ranking, and in this case, it looks like the hospice did not meet this criteria, so they did not earn a point for this particular indicator, so they received a 0 in that column. Now the next 5 indicators are early live discharges, which is a percent of live discharges, late live discharges, some burdensome transitions. There's a type 1, and then there's a burdensome transition type 2, and per Medicare beneficiary spending, and that's in US dollars. And the hospice, again, needs to be below the 90th percentile to receive a point for these particular indicators. And you can see for these measures that they scored points for each one of those. For the next 3 measures, the hospice needs to be above the 10 percentile rank to receive a point. So this is for like skilled nursing care minutes per routine home care day. The hospice did not receive a point for this, so you can see a 0 in that column. And then for the last 2, skilled nursing minutes on the weekends and visits near death, percentage of decedents, the hospice received a point for each of these indicators. So in this instance, the HCI score for this hospice would be an 8 out of a possible 10. Now let's move on to a few more changes that were included in the final rule. So this slide is in regard to Regulation 418306B2. Since 2014 fiscal year, hospices that fail to report quality data have had their market basket percentage increase reduced by 2% points. With the passage of the Consolidated Appropriations Act 2021, referred to as CAA, Section 1814 I-5AI of the Act was amended, and the link to the CAA is listed on this slide, and also you'll find it in the resource section. So this amendment changed the payment reduction for failing to meet hospice quality reporting requirements. It's been increased from 2 to 4%, and beginning in fiscal year 2024, for each subsequent year, the Secretary shall reduce the market basket update by 4 percentage points for any hospice that does not comply with the quality data submission requirements for that fiscal year. Any reduction of the percentage change only applies to the fiscal year involved and does not impact any subsequent fiscal year. And there was another change to a regulation, 418.312B, was revised to require the collection of administrative data. Paragraph B1 includes the existing language on the standardized set of admission and discharge items, and paragraph B2 requires collection of administrative data, including Medicare claims data, which can be used for hospice quality measures to capture services throughout the hospice stay. So this graphic just shows the new HQRP requirements. Now finalized through rulemaking, the HQRP combines sources of data from the hospice item set, the CAHPS hospice survey, and administrative data for Medicare claims. And the quality measures are NQF number 3235, the HIS-based composite measure, the CAHPS hospice survey, and the 2 claims-based measures, HVLDL and the HCI. Now let's go to another polling question. So based on the fiscal year 2022 Hospice Final Rule, how will hospices report the visits for HVLDL measure? Is it A, visits can still be included in Section O and submitted by hospices with other HIS data? Or B, CMS will rely on the data from hospice claims? Or C, hospices will need to email CMS to let them know once the patient dies? Okay, I think we can display the answer now. So most everyone answered B. Based on the fiscal year 2022 rule, how will hospices report the visits? CMS will rely solely on the hospice Medicare claims for that information, so you won't need to submit anything to CMS for this new measure. Okay, so how about the new Hospice Care Index, HCI, contains which of the following indicators? Is it level of care provided, frequency and timing of clinical visits, the number of hospice patients who agreed to a volunteer, D, Medicare spending, or is it A, B, and D only? Okay, I think we can display the answer now. So it looks like most of you chose E, which was A, B, and D only, and that's correct. It does not include the number of hospice patients who agreed to volunteer. So now I'm going to turn the slides over to Charles Padgett, who's going to walk through the public reporting changes for the HQRP.
Thank you very much, Brenda. Okay, I'm just going to cover some of the public reporting updates that were included in this fiscal year 22 Hospice Final Rule. The hospice quality measures are publicly reported on Care Compare. CMS publicly reports these quality measures so that consumers can compare providers in their service area to assist in selecting a hospice. And Care Compare replaced the original Hospice Compare in December of 2020. And it now allows consumers to select, compare multiple hospices up to 3 at a time based on their quality measure information. And to access Care Compare website, we've included the link here at the bottom of slide number 51. Next slide. The hospice quality measures currently reported on Care Compare include process measures. These will now also include the claims-based measures and report using 2 years of data, so we can report on more as well as small hospices. In time, as we've mentioned previously, we plan to include outcome measures. And I'd also just like to note that hospices with fewer than 20 patient stays will not have their quality measure scores publicly displayed because a score with such a small denominator may not be reliable. Okay, data collection reported or affected, I should say, by the public health emergency So with the advent of the public health emergency, the COVID-19 public health emergency back in 2020, CMS granted exception to hospice QRP reporting requirements for quarter 4 of 2019, quarter 1 2020, and quarter 2 2020. We determined that quarter 4 2019 submissions were appropriate for public reporting, and we included that quarter of data in our posting on Hospice Compare in November of 2020. We decided to hold the November 2020 refresh data constant through the November 2021 refresh. And for additional information on these exclusions, you can view the COVID-19 public reporting tip sheet, and we've included a direct link to that tip sheet here at the bottom of slide 53. The Care Compare website data will gradually return to its expected quarters of data displayed. In the meantime, the HIS and CAHPS data has been frozen as of the November 2020 refresh, as I mentioned. Adjustments have been finalized to alter the quarters of data used for public reporting, beginning with the February 2022 refresh and the resumption of public reporting for hospices. And these changes will provide consumers with more relevant quality data and allow hospices to demonstrate more recent performance. So as I stated, we've adjusted the quarters of data that we're using due to the public health emergency and the exclusion of quarter 1 and quarter 2 2020 data. So CMS will report HIS measures using only 3 quarters of data. Generally, we used 4 for those measures. And we'll be using quarter 3 of 2020, quarter 4 of 2020, and quarter 1 of 2021. And that will be, again, with the resumption of public reporting for hospices with the February 2022 refresh of Care Compare. By May of 2022, HIS reporting will resume with the usual 4 quarters of data. So the data will normalize for HIS measures with the May 2022 refresh of Care Compare. Again, this slide 56 is showing a graph. This shows in orange the HIS quarters in the original schedule for Care Compare, and then in green the HIS quarters revised, or the proposed schedule for Care Compare. So you can see as you look down from November 2020 through November 2021, we displayed the same data, which was quarter 1 through quarter 4 of 2019. And then as we resume public reporting with the February 22 refresh, we were originally scheduled to use 4 quarters of data, which included quarter 2 of 2020. However, since we're excluding that quarter, we will now just use 3 out of those 4 quarters of data. And that will, again, be quarter 3 and quarter 4 of 2020, as well as quarter 1 of 2021. Those 3 quarters will be used to calculate the HIS measures. And per our direction, we stated that quarter 1 and quarter 2 could not be used to publicly report data. Public reporting of CAHPS hospice survey data, it will be reported using the most recent 8 quarters of data, excluding quarter 1 and quarter 2 2020. In May 2023, CAHPS hospice survey data will reach 8 quarters of post-exemption data. So therefore, we will resume public reporting a rolling average of the most recent 8 quarters of data with all quarters of data from the post-exempt period. So the data for CAHPS will normalize as of the May 2023 refresh on Care Compare. Again, this chart here is just showing exactly how the data for CAHPS will look. That it was frozen from November 2020 through November of 2021, and then with the resumption of public reporting in February 22, we'll use the 8 most recent quarters of data that we have. That will be quarter 4 18 through quarter 4 of 2019. We'll exclude quarter 1 and quarter 2 of 2020, and then we'll additionally use quarter 3 and quarter 4 of 2020, as well as quarter 1 of 2021 as we resume public reporting. And then you can see as you go down for each refresh, the 8 quarters of data that will be used for each of those refreshes, excluding Q1 and Q2, and then finally with the May 2023 refresh at the bottom of this chart, you'll see that all 8 quarters of data are post-exemption, and data will normalize for a CAHPS hospice survey. Next slide. Claims-based measures. So the Hospice Quality Reporting Program claims-based measures will be updated annually in alignment with most post-acute care claims-based measures. Claims data for calculating measures will be extracted at least 90 days after the last discharge date to balance timeliness and completeness of data. As you're aware, hospices can have some time to submit their claims to CMS, up to a year. When that happens, though, if we were to allow all of that time to go by, the data would continue to age prior to being publicly reported. So in order to avoid that, we allow a 90-day runoff period at the end of the last quarter of data that we're using. And once that is complete, we will pull the data for the claims. Claims-based measures will be calculated using 2 years of data. And again, that will help include more, as well as small hospices, in the public reporting results on Care Compare. Next slide. Quality measure changes in fiscal year 22 and beyond. The 7 individual HIS process measures will be removed from public reporting on Care Compare no earlier than the May 2022 refresh. The public reporting of the Hospice Care Index will begin no earlier than May 2022, again using 2 years of hospice claims data. The hospice visits in the last days of life measure will be replaced, will replace the hospice visits when death is imminent measure no earlier than May 2022, and again that will use 2 years of Medicare hospice claims data. And the provider catalog will display the data from the 7 HIS measures, allowing this information to continue to be publicly available. However, it just will not be displayed on the Care Compare side. The provider data catalog can be accessed through a link at the bottom of the main page of Care Compare, and we've also included the link here at the bottom of slide 60 for your reference. Quality measures to be displayed on Care Compare. There are 4 categories here. The first one is NQF 3235, which is the hospice and palliative care composite process measure, comprehensive assessment at admission based on the HIS admission data. The CAHPS, hospice CAHPS, the 8 CAHPS measures created from the caregiver survey results, and these can be found under the family caregiver experience category on Care Compare. Hospice visits in the last days of life, which is a claims-based measure indicating visits in the last 3 days of life. And a Hospice Care Index, which is a single score measure that combines the results of 10 claims-based indicators, which Brenda covered earlier in the presentation. Quality measure reports. So CMS will refresh claims-based measure scores on Care Compare in preview reports and confidential CASPER quality measure preview reports annually. This period of updates aligns with the most claims-based measures across PAC settings. Hospice Care Index and the hospice visits in the last days of life will be included in the preview reports used for the refresh plan no sooner than the May 2022 refresh. And as with the HIS-based measure, should a hospice believe there's an error with the claims-based measure calculation as displayed in your preview report, you do have the opportunity to request a review of the data contained in your preview report. And there's instructions for contacting CMS about that on the Hospice QRP public reporting website. Updates to the Hospice CAHPS survey participation requirements is finalized in the fiscal year 2022 rule. CMS will calculate star ratings for CAHPS hospice survey for public reporting on Care Compare. Prior to public reporting, CMS will have a dry run of the star ratings through hospice preview reports beginning in 2022. And additional details around the timing of the dry run and a review of the star rating methodology will be discussed on a home health, hospice, and durable medical equipment open door forum in fall 2021. Additional data on Care Compare. Since 2019, the Hospice Quality Reporting Program publicly reports characteristics describing Medicare hospice organizations and their patients using post-acute care and hospice utilization and payment public use file data. Hospice PUF data, as we term it, is used to complement quality and can be found on Care Compare. Current characteristics reported include the average daily census, or ADC, levels of hospice care provided, conditions treated, and locations of care. For more information, we invite you to visit the PUF webpage, and we have included that link at the bottom of slide 64 for your reference. Continuing with this additional data on Care Compare, beginning in May of 2021, CMS began to display additional information from the Hospice PUF data, and these data points include the percentage of patients enrolled in Medicare Advantage and hospice services to patients with both Medicaid and Medicare coverage, also known as dual eligible patients. Care Compare will also include a new link to the APU compliance file for hospices. And survey data will be added in 2022 as required by statute. And that's all I have as far as hospice public reporting updates. I now will turn back to Brenda Karkos for a few additional other updates.
Okay, thank you so much, Charles. So here's just a few more updates that we want to review with you all. So the first is that eventually CMS will be integrating HOPE into the HQRP. And HOPE stands for Hospice Outcomes and Patient Evaluation. It's a real-time patient assessment instrument that's currently being tested. CMS's goal for HOPE is to be more comprehensive by capturing the patient and family care needs in real time and throughout the hospice stay, not just at admission and discharge like the current HIS. CMS anticipates proposing HOPE in future rulemaking after the instrument testing is complete. And so here's just a kind of the same graphic we saw earlier, but this will be incorporating HOPE in the future. So HOPE will incorporate data from the HIS that we have currently, and it's expected to become the one tool for the hospice industry. And for more information, you can visit the CMS website. There is a page on HOPE, and updates are posted there, as well as other informational webinars and tools that as information becomes available. So just a few words about the quality measure development for hospice in the future. CMS is considering development of HOPE-based measures, including something on pain and symptom management, claims-based measures to help beneficiaries and family caregivers make more informed choices about hospice care, and also considering some hybrid quality measures calculated using claims, assessment, or other data sources. Now let's look at some of the resources included in the slide deck before we summarize the presentation today. So the resources on this slide, there is a link to the Hospice Final Rule, a link also to the Consolidated Appropriation Act, the Hospice Care Index. There is a video on there which is currently being updated, so that look for an update on that in the Spotlight Announcements page. The CMS HQRP main page is a place you should definitely be going to and look around and see all the different links that are on there for the different HQRP information, and the HIS webpage, where the annual is listed as well as the item sets currently. The HQRP current measure page, again, that with the current measures are being updated, so you'll be finding some information soon with all of these new measures on there. And the HIS manual, version 3.0 is on here, but there is a new version that will be coming out in the next month. For the HQRP QM Users Manual, visit the current measures page. Again, that's the one, the QM User Manual, sorry, is the one that will be posted by October 1st. The HIS manual is current as of right now. Next. HVLDL measure specifications, there's a report on the specifications, if you want details on how that measure is actually being calculated. And there's also a report on the hospice visits when death is imminent and how that was respecified to become HVLDL. There's a link to the Care Compare website and the provided data catalog that Charles mentioned. Next, and this is these are some resources for CAPS, the Hospice Survey webpage, the official Hospice CAPS Survey website, the HOPE webpage that we mentioned. And if you do want to communicate to CMS about HOPE, you can email the Hospice Quality Help Desk at hospiceassessment@cms.hhs.gov. And then here are all the other help desks that are there for your use. Certainly the hospice quality questions. That's the typical HQRP help desk. Then there's the CAPS survey help desk. There's a public reporting help desk. The APU reconsiderations help desk. And then the IKEYS help desk for technical issues or submission issues. You can email them or call them. So now that the webinar is concluded, basically participants should be able to discuss the background of the HQRP. You should be able to list at least 3 changes to the HQRP based on the FY 2022 Hospice Final Rule. Describe the information that is going to be publicly displayed on Care Compare in fiscal year 2022 and summarize some of these updates to the HQRP. And now I'm going to turn it back over to Rachel, who's going to lead us in some of the questions that came in during the webinar.
All right. Thank you very much. For the very first question, since HCI is like a composite measure containing 10 measures, will hospices be able to see their scores on the individual items so they will know which area they need to focus on?
I'll answer that question. This is Cindy. The answer is yes. The claims-based measure scores will be included in the hospice agency-level QM reports in CASPR. And this report provides detail about the measure scores, including for claims-based measures, to support your hospice's quality improvement efforts. Thank you, Rachel.
Thank you. For our next question, I have one. Won't an RN visit and MSW visit on the same day count for the 2 visits in the last 3 days of life?
The RN and medical and visits on the same day do not count. For the hospice visits, last day of life measures, the visits are the hospice provider's proportion of patients who have received in-person visits from a registered nurse or medical social worker on at least 2 out of the 3 final 3 days of the patient's life. While the patient's visits are meaningful, only patients with visits on 2 different days during the last 3 days of life will count towards the numerator for this measure. These visits can be made by either the nurse, the social worker, or both. A resource document containing the hospice visits last days of life specification can be found in the download section on the current measures page on the HQRP website.
Thank you, Cindy. Our next question is regarding CAPS. Currently, CAPS are not required if an agency does not have large enough patient base, 50 patients, I believe. Can it be assumed that CAPS will be required of all patients despite an agency's size?
Hi, this is Lauren Fuentes. I can take this one. So for the CAPS hospice survey, we still do have exemptions for size or for newness. So if you have fewer than 50 survey eligible decedents period, you can apply for an exemption from the CAPS survey, the CAPS hospice survey. So you would need to go to the website, hospicecapssurvey.org, and there's more information on how to apply for that exemption based on size.
Okay, thank you very much. Our next question has to do with claims-based measures. Can you confirm the period for the data that will comprise the claims-based measures?
Yeah, this is Charles. I can take this one. So results for both the Hospice Care Index and the hospice visits in the last days of life indicate that using 2 years of data increases reportability. So CMS will calculate the claims-based measure using 8 quarters of data, and using 2 quarters of data rather than 1 allows CMS to publicly report the scores, as we said earlier, of more hospices and smaller hospices. And so the inaugural display of the hospice claims-based measures would include 8 quarters of data, and that would include quarter 2 of 2019 through quarter 4 of 2019, and then quarter 3 of 2020 through quarter 3 of 2021. And that equals 8 quarters of data.
Okay, thanks so much, Charles. The next question here is about the HVLDL measure. So in the HVLDL measure, hospice patients who are receiving the RHC level of care in a hospice inpatient unit should still be included in the denominator. Is this correct? As long as they have received the RHC level of care for the final 3 days of life.
So for hospice visits in the last days of life, you're correct. They have to have been on service in hospice care for 3 days, and they had to have visits on 2 of the last 3 days of life, and be on routine home care, or RHC, during those 3 days of the last days of life to be included in the measure.
Thank you, Cindy. The next one is, this states RN visits only, correct? LPN visits will not be captured.
Okay, so for the hospice visits last days of life measure, it is only looking at the RN visits. I just want to distinguish that from the Hospice Care Index, which does include nursing visits, and for that measure, the Hospice Care Index, that claims-based measure, the nursing visits include both RNs and LPNs. And that's because we're using revenue code 055X for skilled nursing on the hospice care, on the hospice claim. And so both nursing types are included for the calculation for this indicator on the Hospice Care Index. So there's a distinction between hospice visits last days of life, which only looks at the RN visits, and Hospice Care Index, which includes both RN and LPN visits for the nurses.
Okay. Thank you, Cindy. Our next question is regarding CAHPS. So the person asks, please clarify, star ratings will be based on CAHPS scores only. Is that correct?
Hi, this is Lauren. Yes, that's correct. It will be 1 overall star rating for CAHPS.
Awesome. Thank you, Lauren. The next question here, when can agencies expect their confidential reports to see their scores?
The confidential report, oh, go ahead, Charles.
I was just going to say, so if we're talking about the claims-based measures, we expect that we will release those confidential feedback reports sometime in September, likely, but definitely in fall of 2021. So hospices should have some time with those reports to understand how they're performing and how the measures are working prior to any public reporting that would take place with those measures.
Okay, thank you so much, Charles. This next question is about the HCI measures. Are all payer sources included in HCI measures or just Medicare patients?
So for the HCI measure, which is the Hospice Care Index, it's based on Medicare claims. So it is just for the Medicare patients are included in that measure. But as most people are well aware, Medicare covers well over 90% of hospice payment. So it's a good reflection of the quality of care in hospice.
The next question is also related to HCI measures. When will CMS release the details on the HCI measures, the numerator and denominator, exclusion, other parameters, and how the 10 measure scores will be merged into one?
Those details and the specifications about the 10 indicators are described in the fiscal year 2022 final rule that's currently posted. You can find it either on the Federal Register website or on the CMS Hospice Center webpage, and I believe that's in the resource document with this webinar. In addition, several new documents are going to be posted by the October 1st, 2021 implementation date on our CMS HQRP website on the current measures page. And the page will include all the current measures. And the download section, there'll be a PDF of the current measures, and they'll be available for printing, as well as the HQRP QM Quality Measure User's Manual, which will be version 4.00, will have all the details. And so we suggest you monitor the announcements and spotlight page for notifications about these postings of the materials. Thank you.
Thank you so much. The next question is in regards to CAPS. How are star ratings for CAPS determined? What earns you a 5 versus a 4 stars, etc.?
So we are going to review the methodology that was finalized in the FY 2022 final rule this fall at one of the Hospice, Home Health, and DME Open Door forums. But at a high level, the CAPS, so there will be scores will be calculated for each of the 8 CAPS hospice survey measures, and then when that is finished, the cut points between the stars will be constructed using statistical clustering procedures to minimize the score differences within a star category, and then maximize differences across the star categories to, again, cut those points of 5 versus a 4. And then an overall CAPS hospice star will be calculated for each hospice by averaging their star ratings across the 8 measures. So again, we will go over this in more detail at a future call. Thank you.
Thanks so much. The next question here, what was the reason on why the 7 measures are still being used when they are being replaced by HQRP?
Okay, so let's walk through this. The 7 hospice HIS measures are used for the calculation of NQF 3235. So we need those 7 hospice item set measures in order to make the calculation for the comprehensive assessment measure, which is NQF 3235. So NQF 3235 remains part of our program because it shows, great variability and being publicly reported. But the 7 individual HIS measures, which is what started out the Hospice Quality Reporting Program back in 2014, those measures as individual measures are not showing a sufficient variability, and therefore they're the ones they're being removed for purposes of public reporting. They're being removed from the program, but they're still being used for the purposes of calculating the composite measure, which is NQF 3235. So that's why they are out for purposes of their individual measures, but they are still being used to calculate the composite measure. So I hope that helps clarify it. Thank you.
Thanks so much, Cindy. There's a follow-on to that one. Will the 7 QMs that are no longer going to be publicly reported on Care Compare going to continue to be available for providers to see in the QM report?
This is Charles. Yes, those 7 component measures will continue to be available within the confidential feedback reports for providers so that they understand how they're performing on each of them and how those scores lead to the comprehensive score.
Thanks, Charles. These next few questions are about the HVLDL. So the first one is, with the HVLDL, will the patients that are on service for less than 3 days be counted?
No. So for the hospice visits last days of life measure, it uses the same approach as the hospice visits when death is imminent measure, which you're probably well familiar with. And so the same way that you have to be on service for 3 days, for at least 3 days to be included in the measure, that's the same for the claims-based version, the hospice visits last days of life.
Thank you, Cindy. And this next one is also about the HVLDL measure. So can LPNs be counted as RNs for this measure?
So the LPNs do not count for the hospice visits last days of life measure. The visits have to be from a registered nurse or a medical social worker. The LPNs are not included in this measure calculation, and this is based on when we developed the measure as we were re-specifying it from the hospice visits when death is imminent measure, which, as you recall, included multiple disciplines and had, when we looked at, and because that measure wasn't, measure 2 of that measure wasn't meeting public reporting standards, as we were looking to re-specify the measure, the only parts of the measure that were showing validation with the caps was the RNs, the registered nurse, and the medical social worker. And that is why when we went and developed the measure and realized those were the only 2 disciplines that validated with caps, that's when we went to the claims-based version, and is why we're using the claims-based version and only looking at those 2 disciplines, registered nurses and medical social workers. We would like to include as many disciplines as possible, but they have to validate with caps. And the only ones that validate with caps for the hospice visits last days of life measure are the RN, the registered nurse, and the medical social worker.
Thanks so much, Cindy. The next question here, how can hospices access their current claims-based data to see how we rank?
So this is Charles. So again, we will be issuing updated confidential feedback reports, including the quality measure reports that will include the new claims-based measures on them. So we expect to issue them likely within September, but at least this fall 2021, and you'll be able to then go in and look at your performance on these claims-based measures.
Okay, great. Thank you for that information, Charles. So the next question here, when discussing which quarters will be used to calculate HIS and CAPS data, are you talking about calendar year quarters or fiscal year quarters?
So I'm not sure I really understand this question, but we're talking about rolling quarters. So with the HIS measures, we generally use 4 quarters of data, and those quarters are rolling quarters. So how that works is we begin with 4 quarters of data, but as we advance the data on Care Compare, what happens is with each quarter, we add the most recent quarter to the period of performance, and we drop the oldest quarter of data from that period of performance. And so we always end up with 4 quarters of data, but it's not as a claims-based measure may be based on either calendar year or fiscal year claims. These are not based on either calendar year or fiscal year. They simply would be rolling quarters of data.
Awesome. Thank you for that, Charles. Our next question is regarding the HVLDL measure. So can you please clarify if day of death is day 0, not counted, or is it counted in the HVLDL?
So we're using the same definition we use for the hospice visits when death is imminent. And as we showed on our slides, the day of death is one of the days, and then one day the day before death is day 1, the day before that is 2 days before that is the 2 days before death. And we have that in the slides for this webinar.
Awesome. Thank you very much. The next question here is there any benchmark data that has been shared for the HVLDL?
The information for the hospice visits last days of life measure, we have a resource document that can be found in the download section on the current measures page on the HQRP website, and also is discussed in rulemaking.
Okay, thank you. The next question is related to CASPR. When can we preview HCI scores on CASPR?
And this is Charles. So again, that would be, you'd be able to preview HCI scores on the newest version of the confidential feedback reports, so on the QM reports that we expect to release in September, as I said, or at the latest this fall, 2021. But as soon as those reports are released, you'll be able to see both the HCI and the HVLDL measure on those reports.
Okay, thank you very much, Charles. The next question here is, could you repeat the implementation start date for the HVLDL and the expected first reporting date, same for the HCI?
So for both of those measures, we've stated that we would publicly report them no sooner than May of 2022. And then so for the inaugural display of those measures, we expect to include 8 quarters of data. So for the first display, we expect we would use quarter 2 of 2019 through quarter 4 of 2019, as well as quarter 3 of 2020 through quarter 3 of 2021. And so you'd see we'd be excluding quarter 1 and quarter 2 of 2020. So again, that's quarter 2 of 2019 through quarter 4 of 2019, plus quarter 3 of 2020 through quarter 3 of 2021.
Okay, thank you so much. This next question here, what is the rationale for not counting RN and SW visits on the same day?
There is an expectation of the hospice needing to make visits on the for the last 3 days, at least 2 of the final 3 days of life. And so in order to recognize that definition, it needs to be 2 different days during the last 3 days of life to count towards the numerator for this measure.
Thank you, Cindy. The next question here, is there plans to have HIS and HOPE submitted via iKeys?
That's for, we will be discussing that in the future as we get closer to the transition to iKeys. But and as was discussed during the webinar, when HOPE is implemented, as we expect or plan for future rulemaking, and that has to be after future rulemaking, HOPE will incorporate the any HIS data items. So it'll only be in HOPE. And once we're transitioned to iKeys, wherever we are at that time, whether if we're at the point where HOPE is implemented or it's before that time and we're still at the HIS, we would be using iKeys. But at this time, we don't have any date at this time for planning to be moving to iKeys in the very near, in the near future. So we're still in the key system.
Okay, perfect. The next question here is about the HCI measure. Are the HCI measures going to be publicly reported individually?
So this is Charles. So no, only the composite score will be publicly reported. The 10 individual indicators, however, will be included on your preview reports and also on the QM reports, your confidential feedback reports, so you'll be able to understand your performance on those.
Thank you, Charles. I have a follow-on to that one. How is the single score for the HCI determined?
So the single score is, and I think Brenda was explaining it during the presentation, is a summation of how you perform on each of the 10 indicators. So we take you on those individual indicators. You either get a point, which is 1 point, or you get 0. So if we sum up the points earned for meeting the criterion from each indicator, and so since there's 10 indicators, the highest score you can get on the HCI is a 10. And so if you missed one of the indicators, then your score is 9. If you missed 2 of the indicators, your score is 8, and so on. But that's how the score is calculated to create the single score that's publicly reported.
Thanks, Cindy. It looks like we only have time for 1 or 2 more questions. So the next question I have is, for the HVLDL, does the social worker need to be a master's level social worker, or can it be a bachelor's level social worker?
We have it referred to as a medical social worker, so we don't put a distinction. We don't get distinction on the degree.
Okay, thank you. And the last question we'll take before wrapping up today, will the QM reports for the HCI show federal and state results for comparison purposes?
So this is Charles. So initially we will at minimum provide the national results as well as individual results. But we do expect to be adding state data both at the care compare level and at the confidential feedback report level in the near future. However, I don't have an exact date on that.
Thank you so much, Charles. So with that question being answered, I would like to thank all of our presenters for sharing their knowledge on today's webinar. This concludes the fiscal year 2022 Hospice Final Rule, What Hospices Need to Know webinar. The webinar slides presented today, which include the answers to the polling questions as well as the recording of this webinar, will be posted to the HQRP website. Once posted, we will send you an email notifying you where to download all of the materials. Thank you so much all for attending, and enjoy the rest of your day.